coming. Thanks for everybody for coming. Yeah, I have been doing this a long time, and it's been very rewarding to do it with the council. The council has been great for supporting me through the years, and I haven't been giving the same talk 20 times. I've been giving different talks every year, and sometimes it's hard to come up with a topic. And this year I came up with this is really accidental hypothermia, because a lot of the stuff on hypothermia now has changed. I'm not going to talk about resuscitation hypothermia, so in other words, return to circulation, someone has a code, and we make them hypothermic. I'm going to actually talk about accidental hypothermia and that difficult decision of when are they really dead and when are they resuscitatable. And so we'll talk a little bit about that. So thanks for coming, and that's what topic is. As I've always said with these lectures, if I get boring or if I'm not talking about something you're interested in, but you have something you want to say, just stick your hand up and we'll talk, because questions are always helpful and they illustrate the points. And so I'll go through the pieces of what's new and what's old. But let me know if you have, especially if you have cases or if you have something that interested you as we talk about it. So we'll talk about accidental hypothermia and when to think about what's happening. So this is the case. It's nice to always start with the case. It's a 29-year-old, and she's an orthopedic resident in Norway, and she's skiing with some friends, and she falls through an icy creek, and she's trapped upside down, and the water's kind of flowing around her, and her poor friends are just looking at her, and she's trapped in a pocket of air underneath the ice, and friends can't get to her, they can't break through the ice. She goes unresponsive. After about 40 minutes, after about 80 minutes, they break her out of the ice, and they start CPR, and she's down for 130 minutes, and she gets 90 minutes of CPR. She arrives at a facility where the potassium score for her pH is 6.6. She's put on bypass, and she has the lowest recorded temperature of anyone who has ever survived hypothermia, which is 56 degrees. So basically, she's below room temperature when they resuscitate her. She, after 10 minutes of bypass on ECMO, she gets a defib rhythm back. After about 15 minutes, she has a pulsatile rhythm. At 180 minutes, she's fully rewarmed. 24 hours later, she's in pulmonary edema, she has renal failure. She goes through all the things that people go through in an experience these days. And she survives. And she's the speaker at the 2012 International Conference on Hypothermia, on accidental hypothermia. So she now moved from being an orthopedic resident to a radiology resident. So she actually got smarter somehow during her resuscitation. I don't know how that happened, but she gave one of the lectures, and it was about her experience. But it just shows you kind of what survival is possible with hypothermia and how management has changed. This is the article. Everybody hear me? Yeah. Okay. We had trouble with the mic when I first started. I think we turned it way up, and suddenly the mic decided there was time to be heard. So this is the article that basically came out in the New England Journal in 2012, which basically said this is kind of how to manage accidental hypothermia. So one of the authors is an emergency medicine guy, so it's very good for emergency medicine because it's really for our field, it's kind of getting known nationally as far as experts in some of these things. And really, for you guys, who are the first people to show up when someone has accidental hypothermia, or for us, the people you bring them to, it's nice to be recognized and be part of the process. So, what are we talking about? So get to the meat of the lecture really right away before everybody falls asleep. That's what everybody tells me to do. So this is the meat of the lecture. When are people really dead? If you died before you were cooled, you're dead. So in other words, if somebody has chest pain, they're having a heart attack, they collapse in the field, people run to get help, you come back, they're dead, and they're cold and dead, they're dead, because they basically died of a heart attack, and you're not going to be able to resuscitate that person. If you find somebody who is dead and you start CPR and their core temperature is above about 90 degrees, their hypothermia is not the cause of their death. So that's another easy exclusion. In other words, they're warm enough that hypothermia should not cause their pulseless rhythm or refit. And so treat them as you would treat any arrest, but they're not hypothermic arrest. And then there are other disclaimers, and it becomes situational as we move forward. So if somebody is literally frozen solid when you find them, like their chest is not compressible, they're dead and they're not resuscitatable. So if their potassium, they come to the ER and get potassium that's greater than 12, those people are dead and they're not resuscitatable. Why? Because they've been static or they've been dead long enough that their cells are breaking down and they're not survivable. So special circumstances, we'll talk a little bit about this as we go along. Somebody, a traumatic arrest, trauma does not do well cold. All of the trauma centers will tell you that, you know, for with post-arrest patients, they make them cold. Someone has a, bypass surgery, they make them cold. We resuscitate someone from a VFib arrest and they're not awake, we make them cold. But trauma, to make a trauma patient cold, they do worse. They get hypotensive, their coagulopathy goes up, they get more acidotic. So it's a bad news thing and it's not a good thing. So trauma and death, cold death are bad. Somebody who's traumatized and gets very cold, they're worse to resuscitate than the person who's not. Drowning is a very special circumstance we'll talk a little bit about as we move forward. And then the article is really big on avalanche burial, which we don't obviously get much here in Poconos on avalanche burial. But it's an interesting topic because what happens in an avalanche is sometimes your airway gets packed with snow, and those people are really not resuscitatable even if they are cold. So we talked about one trauma arrest, hypothermia really decreases survival. So those are the big take-home points really, which is, if you died before you got cold, pretty much you're dead. So what does that mean? So Pete, what does that mean? That means that if you fall into a lake, hang on to the ice for as long as possible to get cold before you let yourself drown, is what it comes down to. And basically try to get very cold before you have your terminal event. And then if you're warm, if you're 90 degrees or above, hypothermia is not your problem. If you're frozen solid, hypothermia is unresuscitatable. If all your cells are broken down and you're greater than 12 potassium, which you guys won't know in the field obviously, but that'll be kind of one of the things we look for in the ER. And trauma and cold are not good. So let's talk a little bit about how do you lose heat. Most of the heat you lose is really into the environment, so radiant heat. It basically radiates off our body. So contact with stuff, so contact with cold things does do about 50%, but most of it is really just radiation into the air, and then respiration and evaporation off our skin does the remainder. The article, and I'll show you the actual cut from the article, talks about 4 different levels. Most people look at 3 levels of hypothermia, which are those mild, people with mild hypothermia, so 90 to 95 degrees, normal body temperature, everybody knows is 98.6, so this is 90 to 95 people are mildly hypothermic. People who are 82 to 90 are in the moderate range, and they can vary as far as what they look like. And then people who are below 82 are really severely hypothermic. So what happens when we get hypothermic? We get pale, our pupils dilate, CO2 tends to build up in our muscle, our heart rate goes down. Below 90, the body tries to move kind of into hibernation mode, so blood flow slows down, heart rate slows down, we get bradycardia. And below 86, basically, we kind of look dead, but we still might be alive in there. As you slowly die from hypothermia, your breathing slows down, you get semi-conscious, and we'll just do this through the different stages. Arrhythmias may develop, and people may, we talk about gently moving these people because a sudden shock or a bump can send them into VFib. And then again, they usually have a cardiac arrest where the heart stops, but that doesn't necessarily mean they're unresuscitatable. These are the stages from the New England Journal article, and it's really just hypothermia, and they really do 4 stages, which are very similar to the classic ones we always learn. And the treatment, which we'll talk a little about, is changing. And what I mean by that is the first 2 stages are people that we normally think of as cold, but the second stage kind of looks at impaired consciousness. And those people are getting passively, externally rewarmed or rewarmed with air and the kind of things we normally do. And then they're really looking at the unconscious person or the conscious person with the unconscious person, the person with no vital signs as maybe those people need to go to an ECMO center. That maybe these are the people that with ECMO will do better over time. That we can support these people and we can try to passively warm them or actively warm them in the emergency department. But what it comes down to is they maybe do much better if they get to an ECMO center. So we talked a little bit about mild hypothermia, which is again, just below normal body temperature. You start to shiver, and then you can't really control your shivering, and it's really just because it's your body's attempt to stay warm. And you can really start to having trouble doing complex motor skills. You can still walk, but climbing or doing a lot of physical activity becomes very hard. And you start to basically constrict. And that's why alcohol, everybody talks about alcohol is bad and hypothermia. And it's really because it vasodilates, so you're going to increase your heat loss. So obvious treatments for mild hypothermia is to get the person out of the cold, remove wet clothing, insulate the person's body from a cold ground, monitor breathing. This is one of my favorite, shared body heat, so you guys can line right up to the stretcher for the person and try to warm them up. So that's totally acceptable, and I support that. Anyone want to take I'd be the patient, not your partner. So you can apply heat, don't apply direct heat, but you can apply some heat around the person, but not directly on the skin. Because if they're cold, they're not going to feel it, you can burn the skin. Don't rubber massage again, because you're going to blister that tissue or that tissue. And I'll do a little bit at the end about frostbite and some chilblains and stuff like that, some obvious cold type of things. You don't attempt to warm just the legs, or arms, just try to do the whole body. Again, we talked about no alcohol. And then rewarming, if you're stuck out in the cold, rewarming should be done totally at one time. In other words, don't, if you're stuck out, don't try to rewarm and then get cold again and rewarm. The refreezing, the re-injury is much worse than the initial injury. So in other words, if you have to hike out completely and then rewarm as opposed to stopping and rewarming partially and then going out. So other passive rewarming is basically you're using the person's own body heat that's still being generated to maintain and bring their body temperature back. So people that are mildly hypothermic, you can bring them back by slowly rewarming them and using their own body heat. So basically using that normal process of where they dissipate heat from their body, you're going to kind of try to contain that. You're going to try to decrease evaporation, you're going to kind of decrease conduction and convection away from the body. So basically warm blankets, putting warm things around them, insulating material, trying to keep their body temperature up with their own body heat. And that's passive rewarming for the mildly hypothermic person. They talk about wrapping people, with some heating pads, wrapping, slightly making people cold now post-resuscitation by putting ice packs in those areas, putting warm packs in those areas, and kind of wrapping them up. So moderate hypothermia, where the core temperature goes 93 to 95, these people start to become kind of dazed and confused. They lose fine motor skills, particularly in their hands. They can't zip their parkas anymore. They can't really do normal tasks they normally would. They can't dial a phone. So there's restricted blood flow, slurred speech. They get fairly violent shivering. And the classic thing people talk about is paradoxical undressing. When they find people who have frozen to death, a lot of times they've taken their clothes off. And no one really knows whether that's a thing that just happens with cold. They just think it's a confused behavior that people start to lose their sense that they're cold, and so they tend to undress. So basically, they're not unaware of how cold they are, and they just start to really take clothing off. Because a lot of times they'll take off their parkas, they'll take off their snow pants, and then they call it paradoxical undressing. And it's an apathy that comes when you get very cold. Your body just starts shutting down, and there's kind of a flat affect or I don't care kind of affect. Severe hypothermia, 92 to 86, that really life-threatening cold waves. Shivering occurs in waves that are violent, and then there's pauses, and the pausing gets longer. It's basically because your body is trying to generate heat through the shivering, but then it starts to realize it has to save energy, so it kind of shuts your muscles down and tries to preserve your glucose in your metabolism. So basically the shivering will stop. You really don't walk at this body temperature, you start to basically just curl up and want to go to sleep. And you start to get muscle rigidity, poor peripheral blood flow, and basically everything tries to centralize your body, just tries to keep your heart, lungs, and brain alive. Pre-hospital setting, what do we do we talked a little bit about passive rewarming, so warm the person up, put warm packs around them, those kind of things. For the severely hypothermic person, we're going to kind of just make sure they have an airway. We're going to look for peripheral pulses, and really they may be in a very long bradycardia, so you may have to really feel for a pulse. So really take your time and give a minute to listen and feel for a peripheral pulse or a carotid pulse, because it may be very hard to get a pulse. and then they're being extreme bradycardia, so if you put them on monitor, they may be very, very slow. And the risk is, again, if they're asystolic or bradycardic, that they can go into defib. So basically, gingerly take care of these people. Now, sometimes you do have to do compressions. If there's no pulse, you're going to start compressions. But you can gingerly try to do compressions, just try to kind of do compressions the way you normally would without a lot of jarring and motion. And just like as I was writing this, I thought this is going to, I got to start to introduce stuff in the air. People are going to go to sleep. So of the 700 people that died here in the United States from axial hypothermia, most of them are in California and Florida. And a lot of that is because of the large number of homeless people and the weird temperature swings. If you've ever been to San Francisco, it's either like really warm or it's freezing. And California is really wide, Florida has really wide degree temperatures, so unfortunately they're number one hypothermia. So you put somebody on a monitor who's significantly hypothermic, and they have these Osborne waves, so they have basically a normal P wave, and then they have a QRS complex that shows this little J wave. Again, bradycardia, Osborne wave are the classic things for our board exams. There's a prolonged QT QRS complexes. You can have shivering artifact, which is pretty common. It's very hard to get a kind of a straight EKG on people if they're really cold and they're awake because they're shivering enough that you have trouble. And then again, they can go into cardiac arrest, VTBF, or the asystolic. This is kind of EKG, somebody with Osborne waves. When I first moved to the Poconos, that came in January. We had a family, 3 kids and a mom who fell through the ice. I don't know if anybody remembers that years and years ago. This was actually one of the EKGs on one of the kids. But they all passed away. But it's amazing how cold people can get, and you can still attempt to resuscitate them. Just to throw in, we talked a little bit about, I'll talk more about hypothermia, treatment hypothermia, but talk a little bit about avalanche, because it came up in this article and I thought it was really interesting. If the patient is buried long enough to get cold, then hypothermic is not the cause of the arrest. So 35 minutes is kind of the magic number in avalanches. And what I mean is if you dig the person out and it's under 35 minutes, they can only get cold at about 10 degrees an hour, 10 degrees C an hour. So basically 35 minutes for avalanche teams is really if they get them out 35 minutes and they're dead from being crushed, or they're dead because their airways packed with snow, and they're not hypothermic arrest. If they're over 35 minutes, then you have to start to think that they survived the avalanche, they got cold, and then they died from, they're arrested from the hypothermia, so they attempt to resuscitate that people. So 35 minutes is kind of a big magic number in avalanche. And then again, when avalanche survival, they look at who's really dead and severe trauma. So basically, if somebody's really traumatized, airway packed with snow, then they probably had a toxic arrest. And if they're in a pocket of air and they cool down and they're over 35 minutes, then they attempt to resuscitate these people. All right, so we'll talk a little bit more about active rewarming. So when do we start to really actively rewarm people? So somebody's cold, you guys find them, you do the passive rewarming things, you try to put heat around them, you try to basically maintain their body heat with blankets and stuff, and then how do we actively rewarm? So somebody who has an altered mental status, somebody who has some cardiovascular instability, these people usually have fairly severe hypothermia, so they're below 90, and they're not rewarming well on their own. In other words, if someone can start to really start to shiver and generate heat, if someone really starts to perk up, then they're starting to move in the right direction. But for some people, they're not, so those people want to more actively rewarm. This is actually the algorithm from the paper, and it basically goes 2 ways. It basically goes, if they're basically unresuscitatable, discontinue CPR, I'll go through that part, and then basically, passive rewarming, then active rewarming with heat or with warm liquids. But the old concept of like chest tubes with warming peritoneal, fluids through the chest tube, peritoneal warming in the bladder, those things are kind of going away. People are moving towards getting those patients to an ECMO center. So pre-hospital, we talked a little bit about this, obviously, for Jack Nicholson from The Shining. Obvious signs of irreversible death, so severe trauma, obviously if someone's a DNR, you're not going to rewarm them. Airway packed with snow, frozen chest, death before cold exposure, core temp above 90. So from the paper, consider termination of CPR. Those people are unresuscitatable. In pre-hospital event, don't delay transport. If there are no evidence of perfusion, then you have to start CPR. And again, it's gingerly starting CPR so that and obviously all of us know it's not a gingerly kind of thing to do CPR on someone, but move them as little as possible. Don't drop them. No excessive bumping, no aggressive attempts at movement. And these people sometimes can go back and you can shock these people. They recommend three attempts, but you can shock these people, and there have been documented cases of people going back to EMV at very cold temperatures. So think about that as far as resuscitation. If they're unsuccessful, don't worry about it. Just continue with CPR, and basically, as you warm them up, you try to defibrillate them again. Don't delay transport. Gently intubate these people. Again, 3 doses of epi, gentle movements, bradycardia can convert to VFib, and consider treatment in an ECMO center. So, when I'm talking about ECMO, I just really want to talk about what do I mean by ECMO. So ECMO is extracorporeal membrane oxygenation. So basically, it's based, or you can simply use the term extracorporeal life support. It's basically a heart-lung machine, just like they would use for bypass surgery. So you're taking a person and you're basically taking their life support and putting them on a pump. So you pump their blood, you oxygenate their blood through a device, and you take away all the work of oxygenating and moving the blood around. And basically, it's a bypass machine. And used for years in bypass surgery, but now also used for people who have severe lung disease, who have severe sepsis, things that basically you couldn't resuscitate before. So basically, you're providing both cardiac and respiratory support. Blood's going through the machine and it's being pumped. Blood's going through the machine and it's being oxygenated. And it's just another way of basically, as the blood goes through the machine, you can warm these people up, and with the warming, you can resuscitate them, and that's really the best way to get them warm fast. So just basically, the machine basically pulls venous blood through a large catheter, goes through a pump. Basically, it's oxygenated, it's warm, and it goes back to the patient. So we use a lot of kids now for neonatal resuscitation for kids who their lungs are not mature enough, they can basically bypass them and use it again for hypothermia. So the paper advocates transfer to ECMO center if it's within 6 hours. The patient has a good history for accidental hypothermic arrest. So basically, like our orthopedic resident, she had it clearly trapped in an air pocket. She got it very cold. She's a prolonged, event as far as hypothermia. She's a prolonged resuscitation, but she's still a viable candidate because she really got cold over a period of time before she arrested. Talk about transfer, even with the return of spontaneous circulation. What am I talking about there? Well, even if somebody has return of spontaneous circulation, they still are going to have some significant lung disease. Just like our orthopedic resident, she had significant kidney disease. So a lot of these people wind up on ECMO just for basically lung support over time. So you've got to think about it as far as where does this person belong? If you resuscitate them and they really get back to circulation, is it something where you can get them to a center where they can be perfused with the machine and basically until their lungs and their kidneys and other things recover. So hypothermic patients from the paper who experience this cardiac arrest, the survival rate for ECMO, and again, these people are selected, the people are most viable to the ECMO centers. We're looking at a 50% resuscitation rate in some of the patients if they're treated with ECMO, and 10% if they're not sent to an ECMO center. So again, something to think about. And what does ECMO bring? Well, it brings essentially a room full of resources to the patient that sometimes other hospitals don't have. So arrhythmias, I just talked a little bit about, we talked a little bit about the heart being very sensitive to arrhythmias, but think about it as far as you can precipitate ventricular fibrillation, and it's just a little blurb to basically say aggressively rewarm, but you have to worry about the fact that they may not respond to drugs and they may not respond to shock, and that's okay. In the ER, you can actively rewarm these people with air. So classically, we use an air hugger, so forced air warming to transfer heat. You can actually immerse these people. Immersion is much more common now with hypothermia, where we'll put people in a cold bath, but you can start to try to immerse some of these people in a warm bath to try to bring their body temperature up. Disadvantages of this is just it's very hard to treat somebody when they're basically floating. But it's a way of warming people when you don't have access to anything else. Again, air hugger is kind of the best way for us for warm diet fluids, those kind of things. So I hate hypothermia. Let's just talk a little bit about some other cold-induced injuries and stuff. Questions on the hypothermic part? Issues? So the big change and the real reason I brought the topic was because I think there's a real push now to say if it's a good history for someone who really got very cold and then looks like they passed away, those people are really benefit from warming and then warming at a center where they can be put on bypass if they need it. And the exclusions we talked about, I'll just review them at the end. So, question, sure.
Where are centers that are?
Valley is ECMO, St. Luke's has ECMO, we have ECMO. Those are the big ones close by. I don't know any in New Jersey until you get maybe to Huntington or somewhere further east. North Scranton would have ECMO.
If the time is long enough, would that be a flight?
Yeah, it can be a flight from the scene. So if you have a good history, and if it's somebody who's resuscitated, you believe is resuscitatable, you can fly from the scene. Yeah, I think it's a perfectly appropriate use of the machine. Now, the question is, are they really, did they die and then they're just cold and dead? And you have to get that from history. And that's always the hard part on our end. I mean, I can remember being in Philadelphia and Philly Fire Rescue would bring it until they dragged out of the river. And it's always that question of, did they drown or did they just get cold and then they went under? So it's sometimes a very hard decision. Most of the guys were partially decomposed, so it was kind of easy. Or the mob had shot them or something. So it was much easier to figure out. But those are always the questions: how did they die? Orthopedic residence is kind of a perfect example because she got trapped in an air pocket so she could breathe, and then she got severely hypothermic. So those are the cases. We had a case in New Jersey. I was at Jersey Shore Medical Center right out of residency, and we had it was an 8-year-old fell into the ice and hung on the ice until he became unresponsive and slipped in, and he had a 20-minute underwater time, and we resuscitated him to full recovery and went back to his school, returned his class. So I remember walking through the ER like 2 weeks later, and it was just people were amazed he was alive. So it is something that you have to think about and just think about resuscitation. But they do better at an ECMO center long term. So, sure.
How much do you actually have to worry about acid?
It can be severe, like orthopedic residence 6.6 was for pH, so they can be severely acidotic, yeah. So that's impressive, how acidotic it can be. But the problem is, they're kind of cold and dead, so you really can think about rewarming and maybe you can reverse all that. Now she had multiple in her kidneys, had trouble, and she had severe lung trouble, and so the acidosis is not good, or perfusion is not good. She's going to have an organ injury, but they are resuscitatable to a certain extent, even with the severe acidosis. So it's one of those things where you kind of have to throw the numbers out. The old number actually for potassium used to be 8, but there are people now who survive at 10s and 12s. So they use 12. People use 12 as a cutoff as far as, and that's helpful for us in the ER because we get somebody in and they have a really high potassium, and you over 12, you're going to say that says you can stop everything. It's fine, time to stop. But under that, and somebody who's got a good story, it might be someone we should go to an ECMO center or someone who we continue to try to resuscitate.
To hospital, all you can do for them is rewarm them.
Rewarm, again, airway, breathing, circulation, so the classic thing. So if they need to be intubated, intubate them, IV access and fluids, and then passive rewarming and just gentle movements and those kind of things. And then again, like Devin said, you can think about lines who did a good story and somebody who think is severely hypothermic and got hypothermic, and that's the cause of the rest. Good question. Anything else? I'm just going to talk about just some other cold injury, just things to think about. So I covered that earlier. Okay, so what is, I love this term, crossing the knife. That's why I got these slides in. So what is frosting? So it's freezing of the top layers of the skin tissue. It's generally reversible. So this is not the hypothermia we're talking about. This is really just skin exposure. So it's a white, waxy skin. It's kind of rubbery. There's numbness. Mostly happens in your cheeks, in your earlobes, and the tip of your nose. You know, Jack Frost on the tip of your nose. And rewarming by basically gentle, either warm fluid, warm air, putting the body part against an armpit or a stomach. These classically people put their hands in the armpits. That's kind of a way to kind of get rid of frosting. Don't rub because it can damage the tissue more. But it's cold exposure and it's mild cold injury basically to your skin. So just something to think about. Chilblain, or people talk about Perno, is a little more significant frostnick. So basically that's frostnick that's extended where people are getting more redness and inflammation. There's more of a prolonged injury. Basically, again, the same exposed area, so your cheeks, your nose, your toes, those kind of things. So things that are exposed in peripheral, like your extremities. And it's an itchy, burning sensation. So it's basically we're on our way to frostbite, but it's not quite there yet. And they think some people are more prone to chilblain. They think some people with like abnormal proteins that sludge are more likely to have exposure to cold temperatures and have problems. And you see that because some people are really, their extremities are very sensitive to cold, and other people are really not, are more impervious to cold. So chilblain or Perno is kind of a concept where you have kind of a little bit of irreversible injury. So you basically frostnick, you get red, the skin's irritated, but it goes away. Chilblain, where it's red, it's more irritated, and it'll last for a day or two, and then we'll talk about frostbite. So that's actually where the skin gets blistered or starts to get woody. It basically affects all the layers. There's numbness again, and anesthesia of the areas. And deep frostbite can go down to the muscle or the toes, and can be very difficult to rewarm. So superficial frostbite, like frostnick we talked about, only in small areas. Frostbite tends to be like cold digits and stuff. So you can see the toes there and somebody's hand. So basically think of it like a burn. Treatment is really, rewarming. So you're going to rewarm in like about 104 degree warm water and try to increase circulation of that area, get the blood supply back. Don't rub because again it breaks the tissue down. People won't feel it when you're rubbing and irritating the area. And we're talking about really stages, just like a burn stage. You can stage it all the way down to where it affects the bone and the muscle. Extremities kind of minimize, injured extremities kept from elevated, try to minimize edema, steroid dressings. Most of these people wind up with a hand surgeon or plastic surgery because sometimes they need grafts, but the tissue can look really miserable, and the general rule with frostbite is frozen in January, amputate in July. So in other words, don't really think about losing or taking off tissue until people really demarcate where their injury is, because some of these people, their stuff comes back, the circulation comes back and they're able to recover the digit, even if it looks really bad. So I know there are people, some of the first attempts at Everest and stuff, there are toes in the museums there of people who've lost extremities. And early amputation was the rule in those days, but now it's really, people are waiting and you get much more recovery of digits. So we'll touch on snow blindness. What is snow blindness really? If you're exposed to cold and blinding light coming off the snow, that basically causes a radiation keratitis of your cornea. So basically the ultraviolet light's hitting your cornea and burning your cornea, and so you can get burns on the surface. It's kind of like a welder's flash. You see welder's flash all the time in the ER from these guys. Sometimes don't need the helmet. So it's basically a UV light injury to your eyes. So it's another cold-induced type injury. And carbon dioxide poisoning, I always think of carbon dioxide poisoning when I start to talk about cold injuries because that's a kind of common poisoning that we see, and it's almost always related to the cold environment. And don't forget about the space heaters. With one of the recent superstorms we had, everybody dragged their space heater into the living room and then slept around it, so we wound up with a lot of carbon dioxide poisoning. So 100% oxygen, hyperbaric chambers, but if you don't think about it, you miss it. I remember years ago, it's one of the resorts now that's closed, but in the middle of July, we had a couple from California flying on a honeymoon, and they get to a resort, and they start vomiting. The wife starts vomiting, and the husband brings her to the ER. And while she's in the bed vomiting, I'm thinking she has gastroenteritis. The husband starts throwing up too. And I thought, he was like, we think we had peanuts on the plane. And I was like, well, you can eat bad things, but peanuts turn out to be really bad things. And she had like a really bad headache, and she seemed a little confused, and he was much more alert than she was, but he was still very nauseous. And I said, when you came, other than eating the peanuts, what did you eat? Because I still thought it was something they had ingested. And he said, no, we really were fine. We ate peanuts on the plane. We got here, we got to the hotel. We're in a little separate condo outside the hotel, and it was, the air conditioning was on full blast. So we turned the air conditioning off when we went to bed. And the wife, as she kind of woke up, said, well, I turned the air conditioning off, but then I turned the heat on. And it turned out that the heat in the little condo they were in was bad, and they were carbon monoxide poisoned. They both had carbon monoxide levels over, I think it was 35 or something like that. So they both had carbon monoxide, and that made them sick. So think about it, you know, anybody who looks like they have a flu, who's had an indoor environmental exposure, and we see it in cold all the time, cold weather all the time. All right, so summary again, cause of death. If your cause of death occurred prior to cooling, you're dead. If your temperature is above 90 prior to cooling, it's not heat-induced. If your temperature is above 90, you're not heat-induced death. It's basically, you don't have to treat those people for hypothermia. If you're traumatic arrest and you're cold, you're dead. If your chest is frozen, you're dead. If your potassium is greater than 12, you're dead. So those are all really the exclusions. And other than that, really, the stories are interesting, and resuscitations are possible. So think about them, and those are the big exclusions.